Thank you, Vivek and CRSF Foundation, UHAPO, Dr. Kumar. Last year, I was a panelist sitting and answering the question related to the insurance, and now I'm moderating. So my job is easier to ask the questions to the experts. I'm very happy and honored to moderate experts in the field. So today's panelists are Mrs. Deepti Bhaskaran. She's head strategic initiative, Clinikk Healthcare. The next panelist is my mentor, teacher, guru, friend, and senior colleague, Dr. Kumar Prabhash. Past, he was the head in the medical oncology department, and he has been guiding us more than a decade. Mr. Maulik Chokshi, he is the deputy country director, Access Health International. He has worked in public health sectors and government policies, designing government policies. Dr. S. Prakash is a former MD at Star Health. Again, I have read about him. He has been instrumental in getting mass healthcare. Dr. Bakshi is a professor at AIIMS, and he has been instrumental in many protocols in pediatrics. Dr. Vijay Sankaran is a group chief medical officer at Mediassist, and I assume before Mediassist, he has worked in other insurance like Religare and other insurances. So we'll start. Do you have the slides, or I'll start with the questions to Dr. Kumar Prabhash. Kumar, sir. So, the cancer treatment is evolving. Decades before, there was hardly any systemic treatment. Surgery and radiation was the key factors for cancer. Then slowly, chemotherapy has become backbone, pediatric tumors, then solid tumors. Then various treatment in the form of the immunotherapy, bone marrow transplant, oral targeted therapy evolved. I remember 2009 when the use of Geftinib started, and the cost of Geftinib was at what cost we get osimertinib today. And the responses we started getting, and we knew that this subset of patients are going to get response, but the cost was a major hindrance. And we knew, there were government patients, like say railway, but on the other side, there were patients with limited insurance, and this treatment through insurance, they could access only for a month. So there are differences in terms of the access to the healthcare. The second thing is these patients were in the transition from chemotherapy to the targeted therapy, which is oral therapy. And, most of these treatments can be designed by the biomarkers. So we need to do investigations. And if some patient is stable, if the patient is stable, you don't need to admit, you get the biopsy done. And when the report comes as EGFR or ALK, you just have a treatment for ALK in the form of tablet. Now you don't need to admit. So there are insurance perspective to this, because different insurance companies may allow for the admissions, don't allow for the admissions. If there is oral treatment, there is no need of admissions. So these are the challenges I do face on a regular basis. The investigations done without admissions are rejected. So the treatment is very different for different patients. There are complications arising from it. And now we are heading towards immunotherapy and CAR T therapy and very expensive therapies. So how do you face these challenges in the Apex Institute like Tata Memorial Hospital? Because you have many support groups, and then I will take the second questions.
So, hi Bharat, thank you for kind introduction. And what you rightly suggested, that there are many issues and there are many hues to the problem people face as far as insurance is concerned. Yes. And one of the things first, it starts with that at this moment, if you think this amount of insurance is good enough, and then you have some good therapy tomorrow, and what you also suggested, and suddenly you realize that that was not good enough. You could have taken, but somehow where to have those lines drawn that you say, hey, what amount of insurance I take, which will be good enough for me next 10 years, 20 years down the line. Because if you take insurance at age of 30 or 40, by and large, you end up requiring in age of 50 or 60. And whatever insurance you take, that devaluation, the way of money happens by the time it reaches there, and you keep wondering. So that is the first aspect, that some way that you should be able to get treatment needs to be there. some perspective to people who take insurance, that what amount will be good enough for them. Second, that whenever newer therapy comes, somehow the agreement, what has happened between the customer and the insurance provider, what was there 10 years back. So immunotherapy came now, and someone who has taken insurance 20 years back, given the best of the premium, now suddenly they realize in that heading, immunotherapy is not written. But it is none of his fault. He put the best of the premium possible. He paid all the premium for 20, 30 years. Now today has the treatment has come. It is good. We want to take it. We say, because the treatment came now, what do I do now? In spite of doing the best effort, what I did at that time. Third is, I think so, I'm sure many of people can blame us also, knowing the details. The way we say, hey, agar hum doctor ke paas jate hain, doctor should provide all details and then say, hey, do you listen to each line and each word? Same way for insurance, the pages are so many that you sign it. You don't read each and every word and every line of that agreement what we sign. And then you realize again what you were suggesting, admission required or not, tablet or not, how many days admission required, does the daycare qualifies for treatment or not, and then the patient was smoker or not. I know that is something pretty surprising which comes on daily basis or I will say regular basis to us. That patient was a smoker, and that's the reason that patient should not get insurance claim for the treatment they received. But I don't know, somewhere the clause is written the way it is interpreted. It is that it's that way that if you are taking tobacco, then they don't get insurance claim. So these things are issues there where the consumer and the provider has to have the dialogue, how to ensure that they don't face this issue when they have paid the premium, when they have agreed with well-meaning people. At the end of the day, when they require those money to get the treatment done, and I think so, it primarily comes from that does the company is able to have some form of profit or not, and that's a challenge because of how much is the penetration of insurance in our country, how many people take it, and then how many people required to have the money to get the treatment done. That may be partly deciding. So many factors to it, but yes, at the end of the day, you have a whole lot of people, in spite of having only 8 or 9% people having health insurance at this moment. If that was the last I remember, people do get frustrated when they have paid the premium well from their side.
Yes, you have almost covered all the aspects which I do know come across in private setting. Right from paying the huge amount of right now, I'm treating a 87-year-old of hepatocellular carcinoma, fit, young-looking guy, 87-year-old, and he has a background of working in advocacy for the insurance from the insurance angle, not for the patient's group. And his claim was rejected with a cap as well as the oral because lenvatinib was the first line, and now he is on immunotherapy and targeted therapy. So in spite of paying for 10 lakh, which could have been 30 years back, is a huge amount. 10 lakh is a huge amount 30 years back. So what I feel, yes. So what I feel, like what the addendum we get in our histopathology report, something news comes up to the pathologist, or some mutation which not actionable 10 years back, and down the line you get a molecules, right? So it is like the insurance agencies also should have addendums coming up. If the new treatment come and the dialogue has to happen that you have taken an insurance 30 years back. Now the treatments are also evolving. So we are providing a package, you can upgrade this. There has to be a dialogue. You can't just simply deny. From as a caregiver, I really feel a pain of not getting after paying for 30 years or 40 years. So there has to be a dialogue, which you rightly quoted. Now, as a clinician, we have limitations. We can't go and fight with them because I have personally tried going and talking to insurance companies for my patients. Now, apart from our clinical work and lab work and research work, this is an additional thing, and it requires a lot of follow-up. This requires a lot of follow-up. So I feel, do you think that the patient should form a group like an advocacy group, or you have a lung connect group, which may help to solve? They don't have anything in their hand to solve, but do you think that will be of any help and how should they have their approach?
I have no doubt about that. You require a patient advocacy group. The saying in, we have saying in Hindi and English both. You need to be in their shoes to know it. As much we think that we know it, what the patient goes through, what they require. But having said that, we know that we are not in their shoes. As much we claim, we end up being a doctor. As much we talk to them, as much. So yes, I think so. The patient and the caregiver, they know the best. Their voice needs to be there, and also they are the most neutral voice. As much I may keep talking about my patient requires this, I am a biased person as a doctor. So as a patient and the caregiver, they are the people who are the most neutral. Not only being neutral, they are perceived neutral in the society. So they speaking and their voice will be heard far better. The people will be far receptive. Any administration will be far receptive to the voice from patient and their caregiver than as compared to anyone from either clinicians, from any healthcare worker, or from the companies who may be willing to present things, or from insurance. But I think so. It will be ultimately a patient and the caregiver. So their voice is important, and we know that worldwide, if they speak, people do hear them.
Thank you, sir. You have always shown a vision. Decade ago, you shown what molecular work can do, and setting up a advocacy group, helping them and designing them. And I think lot many advocacy groups are coming up and trying to solve these issues to what they can do. The next, please go back to the previous slide, Vivek. So our next panelist is Dr. Vijay Sankaran. He has an extensive experience of different insurance companies. So now we always talk doctor's perspective, advocacy group, and patients. But there are some queries from the insurance companies also side. We have to hear those. Like there has to be a crosstalk. One cannot have only one group talking. But Dr. Vijay Sankaran. So the claim settlement and the reimbursement denial, it's a big thing for us. No, it happens on daily basis. Not for all. There are companies who don't ask unnecessary questions. I'm very serious about asking, putting that word unnecessary questions. When the data is in public domain about a disease and the drug, sometimes, I'm not saying every time, the questions are really, asked repeatedly. One example, I'll give the exact cause of the cancer. Now, everybody there are oncologists over here, very senior oncologists over. The day we'll come to know the exact cause of cancer, and I know Dr. Kumar also agreed to my statement that we will come to the cure. So it's a multifactorial disease. There is no single cause, apart from few cancers where there is single cause. So many times the claims are denied. So I agree that there are two ways problems. There is a lack of awareness and education at patients level also. They don't follow with proper documentation. But there are problems at the other end, on the other side of the table also. So do you think there has to be awareness, there has to be education on both the parties, also the policymakers? As I mentioned in the previous question, that the points which are laid down when the agreement is signed decades before, with the evolution of treatment, new treatments come into picture which are curative and may not be chemotherapy is the only treatment offered to the patients. So with that angle, what is your take, or what is the thing which comes from the company side or the insurance perspective?
Thanks, Dr. Bharat. I think that's a very good question you have asked. See, the thing is that when somebody is applying for insurance, number one, the most important thing there is that they should research it properly, the type of insurance they are taking up, try to understand the uh, coverages and the exclusions, and try to disclose everything that is possible, because insurance, after all, is given on utmost good faith. That is what is true, right? Even the insurance companies cannot go out and investigate and try to find out everything that a person has, it is almost impossible. You understand that. So there are so many diseases around. So that is number one. The patients or the people who are taking up insurance need to first understand the insurance policy and then get into a contract. The second important thing is that there are different types of health insurance. So one is the indemnity insurance, which we are talking about, where insurance covers basically the hospitalization and, as you have mentioned, pre and post treatment. Right? That is the limit of cover which is there in such covers. But there are a lot of other insurance products available in the market, like critical insurance covers, which specifically are designed for critical illnesses, including cancer. These are products which people are not aware of, where a bulk amount is given on the diagnosis itself to the customer. So this bulk amount is what, see, cancer treatment does not end with pre-diagnosis uh, consultations and investigations or the post hospitalization, right? It goes on for years. So it may be a year, a couple of years, and there are a lot of associated expenses like traveling, palliative therapy, the nursing care, etc., etc., etc. There are a lot of things. And if you invest in products like a critical insurance, where a bulk amount is given to the customer at the diagnosis itself. So people should start investing in those uh, covers where they get that amount in the bank, which they can utilize to cover the financial expenses over a period of time. The second problem is that I think even today in India, insurance is not seen as a necessity. Everybody will agree on this standard, right? People feel that I'm okay. I don't need insurance right now. Only when something happens to people invest or try to get insurance. So that is the second thing. So I think there is a role for patient advocacy groups where they can try to. So these advocacy groups can help the larger public to make them aware on the uh, dangers or the financial strain that cancer cause on the entire family financial situation. I think it requires a lot of education either from the government side or through private organizations or through advocacy groups to try to disseminate this information to people and bring them on board as early as possible. One of the panelists just now mentioned the penetration of insurance is very low. It's one of the lowest in the world. The health insurance is something that is the last on anybody's mind. I think once you, so the people have to be aware on the type of product they need to invest in, and the earlier the investment happens, it is better. So that would be my take on it.
So thank you. So you partly answered about the education and penetration. So my second lead question here is the how do we how do we deal with the reimbursement denials and the claim settlement denials? Because see, there are people. I do understand no penetration is a problem because of the social background. Largely people stay in rural area. We can't expect everybody to know and read those. As Dr. Kumar rightly said, this is how there's a big book comes and there are middle agents who are involved. No, partly they facilitate the enrollment, right? Many a time I have come across that the people are told that no, they ask us not to disclose particular facts. This is what happening because no, the agent also acts to increase their numbers. So the middleman is handling and no taking the insurance and facilitating when it comes to the settlement or reimbursements, and lot many denial from the insurance. How we can reduce that number? So it's a fact that it is being denied, not for all, but as a caregiver or advocacy group, they would want that at least whatsoever return. And one other point which is mentioned is no, we should not go into detail that anti-cancer therapy is moving from chemotherapy to immunotherapy and targeted therapy. So lot many companies are coming forward with no cancer insurance, dedicated cancer insurances that may help in the future. But right now, based on the agreement which is signed decades back, the right is getting rejected in few of the cases. Few companies are very good. I will not mention good and bad companies, but there are very good companies, but at the same time, sad to say that no, some companies are really behind denials. So what is your take
I
on that?
agree. So I agree. See, the lot of these denials usually happen because there is lack of understanding on both sides. Maybe uh, from the medical side, the documents coming in are not that clear, and there is another party sitting there. So you need to understand that the doctor sitting in the hospital is a primary caregiver. He is into his clinical work, right? The other side is the other doctors panel, which is sitting away and judging something on what documents come in, right? So if the documents are not clear, either a question will be asked about further detail. If they are answered adequately, the approval may happen. But if the answers coming in are not convincing, then it becomes difficult for even the insurance company people or doctors to be able to judge whether this is acceptable as per the policies, terms and conditions or not. So that transparency has to be there. There has to be a dialogue between the two partners so that there is much ease in the transaction as such. Today, that transparency is not there because there is a so the doctor does not directly speak to the doctor. The treating doctor does not speak directly to the insurance doctor. There is some in between. There is a TPA desk. People manning that are basically graduates. They don't understand medicine. So one doctor is not directly talking to the other doctor. So this is the problem in between, which leads to a lot of these uh, rejections uh, in the in first place. So that is that. And another thing that you brought up is the types of evolving treatments which are coming up. Right? So it is not that insurance does not cover the newer forms of treatment, even though your policies are old. So from time to time, even the regulators sends guidelines, and people also keep updating their products. So the product which was bought maybe 10 years back, today the same product may not be in place because the terms and conditions have changed. And especially for cancer, there has been a lot of change in the last couple of years where the modern treatments, the robotics, or even the oral chemotherapies which have come in, uh, companies have been advised to give cover to this. So though the covers may be limited, they may put limits on payability because these are things that the insurance company is not able to understand. What is the cost going to be? Because you need to understand that after all, insurance is where we take money from 100 people and we expect that 6 people or 7 people or 9 at the most will get admitted. So that is how it is done. If insurance keeps covering for everything, then the cost of the premium will go so high that other people will stop affording that. So it's a catch-22 situation. So insurers also have to understand over a period of time as these become more and more mainstream treatments, the cost also starts coming down on the medical side, and insurance also starts to understand how it works. There is statistical data on which they can work. So that's how these things will come into place over here.
Yeah, I take your point. Very well said. There has to be a interaction. So I personally do try to talk. Many of the companies, if they have a problem, they do talk. But yes, there are skewed deviation, and few of them are not in a position to talk, or they don't want to talk. But largely the channel is open. Again, there is awareness. The awareness should go to all the treating doctors, the patient groups, the advocacy groups, as well as the doctor sitting on your end. So, and that solves the problem.
No,
This is the transparency,
I'd
right
like
word
to
you use.
add
Yes, I completely
I'd
agree.
like to add one thing. I'd like to
Yes.
add only one thing. I remember as a medical graduate, I think in 2000, uh, so there was an opinion that health insurance should be a subject for medical graduates. I think uh, we are the generation actually who are the senior consultants and all, and I think that lack of knowledge is what's currently hurting both the sides. I think over a period of time, I think it will ease out and people will become
Sure, sure.
more mainstream.
Yeah. One has to take the opportunity to educate all. No, once. So I see unfortunately, I have a young doctor who suffered from a brain lymphoma, did not have insurance. His father suffered from cancer way back. He did not have insurance. And I have seen, even a financially well family, how they collapsing. And then what must be happening to a common public? Educated class is also way away from the insurance coverage. So our awareness should start from getting into enrolled. Forget about applying. Obviously, we are there to help to facilitate from the patient end. I request, and most of the companies are doing trying to help out to the patient, because this disease is something which doesn't affect a single patient. It's the entire family. It's the mental burden. It's not only the financial toxicity. There is a mental toxicity equally involved. So we are evolving in terms of all these factors. Thank you so much, Dr. Vijay Sankaran. Next, I would like to move to Dr. Prakash. Yes. Now, with your experience on the clinical side, sir, Dr. Prakash, yes.
Yes.
Your experience from the clinical side, more than 2 decades, and then moving into insurance, establishing a company, taking in milestone ahead. You must have and you have been instrumental in getting a mass insurance coverage in South India. So I read about it. So you have touched from the beginning point of enrollment in the insurance and tackling all the issues which we have been discussing, including the rejection. So it's a fact that there are rejections, but the rejection must be going down in terms of the percentages. So now we are talking a lot about the advocacy group. Have you come across such groups influencing, or do you see any role this group can play while getting awareness, or get more enrollment, or handling the conflict in between the two parties?
Yeah, Dr. Bharat, am I audible?
Yes, sir. Yes.
Yeah, Dr. Bharat. So I foresee a lot of positive role for the advocacy group, because here we need to bridge the gap.
Yes.
A lot of information asymmetry between the customers, the hospitals, and the insurers. So insurers also want to design product, as my colleague Dr. Vijay was talking about. They want to design product based on the market feedback. So advocacy group are the right people to give the exact information on how a product can be designed, because he was talking about insurers being worried about increasing the premium getting increased if too many cancer conditions are covered. But cancer conditions can be covered because there are a lot of problems among survivors and also among people who are early detected and treated, where the financial liability is very less, but insurers are apprehensive about covering those individuals. So they need to be covered. Somebody survives from a cancer, they need to be covered for non-cancer related medical conditions. What if they are going to live for another few decades and suffer from a fever or a fracture? They should get a health insurance. They should be considered like any other normal people. So the right information should reach the insurers for designing a health insurance product which can cover people who are diagnosed with cancer, treated with cancer, or who are surviving out of a cancer. So here, I think an advocacy group have a very, very strong role to play.
No, that is why more and more doctors should go and join the insurance side also, so that they do understand what are the patient's problem. So as you mentioned, the advocacy group can help to know what are the actual demands and how the insurance company can meet. But the rejections, what we see, I don't know whether they are intentional or technical. Technical in the sense based on the agreement which happened between patient party and the insurance company, or is it something which is incentivized? No, then the word come intention, that more and more rejections would be better. I don't have doubt that everybody is there to help, but then when a genuine claim is rejected, there are certain questions comes up, and then how to deal with it. As the previous panelist mentioned, Dr. Vijay, that now people are ready to discuss, but unfortunately there are certain circumstances where the parties are not ready to discuss also. So, and I'm not saying the number is big, but yes, the patient parties are producing all the reports. The doctors are ready to discuss. All the questions are answered, but on certain occasions, the claim is still rejected. So then the question comes: the reasons are really intentional or technical? Dr. Prakash.
Yeah, yeah, Doctor.
Yeah, how we can reduce that?
It's very difficult to say whether it is intentional or commercial. So honestly, as a doctor in the health insurance space, health insurance is not a commercial product alone. It has got a lot of values,
Yes.
and there is a serious intention, but it also requires capital. And people have to infuse capital, and they will be expecting returns. So when I talk about rejection, I can foresee one of the main cause of rejection is people not understanding what they are buying. There is a waiting period. There are standard exclusions. There is a pre-existing disease. There are some endorsements. So the policyholders are not, unfortunately, spending time to know what it covers and what is not covered. So that is the main reason for rejection, as I could see. The second thing is, in the designing of the product itself, insurance policies sometimes are very complex, that people in the same industry also cannot choose the right product for them. So this is a continuing challenge I could see. The third is, as a senior doctor, I know the patient, the family for so many years. When they come to me and say that, sir, please don't mention that I'm an alcoholic, because the hepatocellular carcinoma, there will be a lot of questions. Sir, I had some instances of hepatitis in the past. I don't want that to be mentioned. True. And the doctor also knows them and the family for 10 years, 15 years. He thinks that he's doing a help. But actually, it is not a help. In the eyes of the insurers, it is a substance of material fact. And it will be amounting to financial fraud. So when there is a suspicion of such things, insurers tend to reject. So the rejection is due to products, due to the features in the products, due to the customer purposely not disclosing, and due to the customers being naive and innocent. Some customers are very naive, very innocent. Some of them are very demanding and very vulnerable.
Yes.
And insurers want to protect themselves. Even, as a doctor, I could see that how a lot of defensive practice, multidisciplinary approach is helpful to treat the patient. At the same time, multidisciplinary approach can safeguard a treating doctor.
Yes.
So this is the era of cross consultation, and with every cross consultation, there are a lot of investigations, and the treatment cost adds up. So every one of us should understand. Insurance works on two things: what is the incidence rate and what is the average we spend for a claim. So if there are people, even 10-20% of the people suppressing the information and trying to come for a claim, it will affect the balance because the incidence rate will increase. My outgo will depend on the incidence rate and the average IP. If there are, out of 100 hospitals I service, if there are 10% of the hospitals which are trying to do unnecessary investigations, extended length of stay, unindicated procedures, and unwarranted professional cost, all these things will increase my average cost.
Absolutely.
Even if 50% of the people are doing a genuine service, 10-20% of the outliers can tilt the balance. So this is what is bothering the insurance companies. So I think there is a fair role for the advocacies to study the pain points from both sides. And then I am willing to sit with the advocacy group. I'm not talking theory today. I am willing to sit with them and design a product which can cover people who are diagnosed with cancer, and take it across to the nation and show to the insurers that it is a viable proposition.
Yes.
For post this conclave, we can organize for a small group where I can take some volunteers and I can design something and show to the country that people with cancer can be covered, and to the insurers that they can safely do that without much financial liability. This is possible, but it requires a team and a brainstorming. I look forward to the
Sure.
organization arranging for it after this.
Yeah, this is very important point, and the transparency is the key to go ahead, because the incidence is unfortunately increasing, and very rightly said, there are really genuine patients, and the outliers, there are some fraudsters. Because of them, everybody screened, scrutinized in details way, but largely our cancer patients largely. Yeah, so going to the next question.
Dr. Bharat, could I come in here?
Yeah, please.
Hi.
I'm going to come to you, but you can cover in brief.
No, I just wanted to touch upon rejections, I think, because it's a very, very important point. And just wanted to echo some of the points that the panelists before me have already made. But I think when you're looking at rejection, right, the one thing that I think we still need to think about is, why do rejections happen? Okay. And in that, one of the practices of the industry is to, focus more on a very smooth selling process, right? Where the sale is not sort of hampered for, let's say, lack of documents, for a lot of health checkups, for a rigorous investigation and all of that. But what happens at the time of a claim is that's the time when actually there is underwriting, where the patient who reaches the hospital does not lie to the doctor. You will always truthfully disclose to the doctor all the problems. And that is where, you are in a soup if you have not disclosed in the past, or let's say the person who sold you the policy encouraged you to sort of lie or, suppress information. So I think somewhere as an industry, this practice of underwriting at the time of claim rather than at the time of the sale, that shift also needs to happen. Now, if you look at the way industry has evolved, new regulations have said that after a moratorium of 8 years, you cannot deny a claim for non-disclosure, or, other than fraud, you can't deny a claim. That's a very good step, because that's sort of pushing all of us as an industry to make sure that I am selling the policy right. I am encouraging, or I'm making my customer aware, the importance of proper disclosures. So I think that is a focus area that we should not lose sight of. So I just wanted to make this small point in this particular aspect.
Then I would like to extend the question, because what I was supposed to ask you is about the coverage. People take, as Dr. Kumar also mentioned, what is the optimum amount I should take, because the cancer treatments are evolving and the future treatments probably are more expensive. So designing the coverage and the premiums paid, but after that, when the patient gets hospitalized, only the hospitalized amount is claimed. And again, there is a cap on the coverage. Restrictive amounts are paid based on the premiums. So what is your take, and what is your advice to the advocacy group as well as patients? How should how should they upgrade their insurance, or while going for a new product, what should they look into it? Because hospitalization, the entire hospitalization is not covered in many of the patients. It's the restricted at some percentage.
Sure. So I'm going to take that question slightly differently. I'm going to answer this question slightly differently. Let's first start by understanding, why is health insurance right now just sort of confined to covering hospitalization expenses? So in that sense, it's restrictive. And I believe you've also mentioned that if it's oral administration of care, it's excluded. But if it's inpatient, it's hospitalization, then it's included. When you have a financing scheme, so health insurance is essentially a financing scheme. When you have a financing scheme that does not have visibility on a person's health and is not able to make an impact on a person's health, but is there only to sort of pay for a medical expense, especially at a tertiary level, what do? You have a product that's restrictive. You have a product that comes with certain caveats to avoid fraud and abuse. And you also will have a product which will be very, very pricey, especially at an older cohort. So you have been paying insurance for, let's say, 10 years, but suddenly you're 45 and you see your premiums jump to an extent where it does not become affordable any longer. Right now, yes, there have been reforms that have been done in the industry that's made insurance more comprehensive. But as long as the payers and the providers don't interact with each other, you will always find a product that's narrow in scope. right? So you will cover hospitalization, but you will not cover, let's say, oral administration of drugs. But in cancer, it's important that we cover all modalities of treatment, right? So you cannot, I as a customer or I as a policy holder, I should not be at the time of making a claim, should have to worry about, hey, this line of treatment is not covered by my insurance policy.
Yeah.
And I feel as an advocacy group, that is where, you need to come in to sort of say that the kind of insurance that you imagine needs to be end to end. Because you cannot have a product that is only covering for hospitalization, because that's creating wrong incentive. That's pushing people to hospitalization. It's not really bettering any health outcome per se, right? So that as an advocacy group you need to do. But what that will do in return is it will encourage the payers and providers to come together, work together, and form a preventive and promotive healthcare layer. You've talked about how much insurance is enough. Today sitting here, I could answer maybe a 10 lakh is enough, but is it really enough? You have treatment cost of 50 lakh, you have treatment cost of 80 lakh. So how do you look at insurance? You have to look at insurance from the lenses of preventive, promotive healthcare, make every possible effort in the book to prevent hospitalization from happening, right? So if you can embed healthcare in insurance, that's how you will ensure that all the stakeholders in the value chain are aligned in terms of incentives, and that incentive is for a better health outcome. And I think that is the role that you play, the advocacy group need to play.
Yes, well said, well said. End-to-end coverage, this needs to be again discussed by the advocacy group with the healthcare insurance providers. Very well said. So we'll move to Dr. Samir Bakshi. Sir, Samir sir, my question to you.
Yes.
At AIIMS, you work in pediatric solid mainly, and for kids, we are very sensitive, and cure rate is also very high for pediatric solid tumor. So at your institute, how do you see, any example of advocacy group? We have been talking a lot about advocacy group. So in terms of availability of the insurance, a lot is talked about. The advocacy group should penetrate the awareness to the groups or the patient parties, accessibility, and inclusion of some drugs, newer drugs into the schemes. Are they doing a work on this improvisation of the availability, accessibility, and inclusion of newer treatment into the claims or to get the claim passed? And
so I'll give you two examples that I've faced. So I don't have too much experience about insurance companies because I don't deal with them directly. So I don't have experience, but I'll give you two examples, specific examples, where drug approvals required an extra effort. In one, it was successful, and in another, it was not. So one was when nivolumab immunotherapy was approved for lung cancer in India. That was the first drug approval, if I remember correctly. Yes. But it was not approved for melanoma because the market was very little. So obviously the company approached the DCGI for approval for lung cancer because that was a much bigger market. And this is back in, I think, 2017 or so, if I remember correctly. And in 2018, I had a middle-aged lady at the age of 50 with a recurrent metastatic melanoma. And obviously, she was a CGHS beneficiary, and there was no approval for this drug. And this was a curative intent. I consider this as a curative intent treatment for metastatic melanoma. And it was not getting approved. And we had to write 3 or 4 series of letters, appeals from the institute and from our side. And then committees were formed to look into the claim. And after probably 3 or 4 months, the claim got approved. And this lady then got the treatment for a period of 2 years. And I'm glad to say that she is a survivor today. So that was one example, not through insurance, but through a public insurance. I would say CGHS is kind of a public health insurance. The second example I would say, which I did not succeed, was a 17-year-old Hodgkin's lymphoma who required availability for, again, immunotherapy in a post-transplant setting for a relapsed Hodgkin's lymphoma post-transplant. And how the family wished that the patient was just 10 months older. So that creates a problem that had this patient been 10 months older, the same therapy was approved and would have got it. And I want to give you examples that in the US, the Medicare and Medicaid, if a drug is approved in general, but there is an overall approval in the scenario, those claims are considered.
All right.
So those claims are considered, but so in one we succeeded because there was international data. For the other, there was data, but not an approval. But then always approvals may not actually translate into for insurance. I mean, so that humanitarian ground or that kind of approval has to be considered, I would say, in such things. I would just end by saying one more thing, that while these were genuine cases, there are others where advocacies of a different nature may result in approvals based on what you call the passion of getting approvals for the patient or that feelings, but when the success is very minimal, the success quantum is very minimal. And I think one of the classic examples is that there was a push for the Duchenne's muscular dystrophy disease drug to get it approved. And while the benefit was very modest, so from that perspective, I'll say we have to look at the financial aspects of the insurance companies as well to see that they don't get milked out, as rightly pointed out by Dr. Prakash in his previous talk. So it has to be a balanced way of advocacy so that things get done for genuine cases. I would end here.
Well said, sir. No, so your crosstalk with the companies or discussion with the companies at least has a success rate of 50%. One patient approved and the other patient not. As you rightly said, the survival outcomes and the cost effectiveness is also very, very important. So the last panelist is Mr. Maulik. You have been working in public health as well as government advisory to design. So my question to you, when it comes to a large population like India, the number is huge. There are certain gaps, and what gaps do you see when it comes to insurance coverage? There is huge gap. Now, everybody knows that, everybody agrees on the point. Then comes the sum assured, whether it's adequate or inadequate, the premium paid, and the penetration. These are the issues. And what are your views so that we can bridge this gap, so we can close the cancer care gap pertaining to the cancer? And do you think the advocacy group can help it? Because we have been talking to many advocacy groups in India. Fortunately, the momentum has come that these groups are helping to patients, helping to smoothen the journey in cancer treatment. Over to you, Mr. Maulik.
Thank you very much indeed, and it's a pleasure to be here. I think so. I'll give even an economist kind of response to it. Indians are, if you look at our population, we have got high income group, we have got middle income group, and we have got low income group.
Okay.
And I think so that when we talk about covering them, we don't need a same instrument or a same tool to cover them. I think so high income group, we have got private sector, private sector insurance can play a significant role in enhancing the coverage of access to cancer care. Middle income group is an area which I think so we have been struggling for a period of time. There have been some kind of headways done, but I think so we are still struggling. And when we talk about a low income group, I think so where a sizable population is there, I think so around 60 to 70%. I think so we should be kind of, the patient advocacy group should be kind of instrumental in directing them, linking with what state-supported health insurance schemes are. And why I'm using state-supported, because we have got a federal level scheme like PMJ, Pradhan Mantri Jan Arogya Yojana, and when you've got a state-supported scheme where a lot of states like Rajasthan or Kerala or Tamil Nadu have got top-up above what PMJ is offering in terms of more than 500,000 rupees. So I think so when we talk about covering cancer care, we need to look at how the different instruments could be used to cover different population. That's one thing. And that looks at the coverage in terms of numbers. But when we talk about coverage within a policy, I think so many colleagues have made a remark earlier also, that when you take 10 lakh rupees coverage, when you take $1 million coverage, what is it covered? And I think so Deepti made a very valuable point that it needs to be continuum of care. The gentleman also made there. There are certain critical illness plans that are available right now, which gives a lump sum amount based on what their initial diagnosis is. And I think the patient advocacy groups needs to kind of start playing role in making sure that all this basket of options which are available is known to the consumer. I think so there is selective information which is going on. We don't need to kind of rely entirely on private health sector or private health insurance. We completely don't need to rely on public health, publicly supported health insurance, but we need to start using these tools as and when come. So that's one broadening in terms of coverage as well as depth of insurance coverage concerned. I think so. Second thing that's working now, and I think so it's going to be very important is what bringing in the cost of coverage. I think it's a lot of when we talk about premiums, one of the artifact of premium, or what is the input cost of premium, most of the companies do that. They know that certain proportion of premiums are going to get rejected because of XYZ reason. And a lot of times the XYZ reason is information is not available, reports are not submitted. And I think so what, again, at a federal level, what we are doing is creating a HCX, a kind of health exchange, which is trying to kind of digitalize and kind of harmonize this claim processing. I think so it will bring a lot of efficiency in the system. And efficiency can be a driver of decreasing the cost. And if the cost goes down, it gives an opportunity of more penetration. So I think so there are multiple efforts which are going on right now. And when we start doing that, patient advocacy groups also need to play a significant role in kind of making sure that people are aware of all this. As a lot of panelists have mentioned earlier, that lack of awareness is one of the biggest drivers of not being able to access something. Let's say if I'm based in Rajasthan, till $2.5 million, 2.5 million Indian rupees, my health things are covered. Within that package, rates might vary, but I think so there are movements which are going on towards increasing coverage as well as within a package and at a population level. Thank you.
Thank you. Well said. So all the panelists have contributed a significant amount of information. The patient part and patient advocacy groups also do need to educate the general population while going for enrollment of new insurance. Need to have discussion in detail when such unfortunate incidences happen of cancer diagnosis as well as the claim rejection. There has to be effort from both the parties to understand what is the exact problem. I think the discussion, a sound discussion, can solve majority of the problem. Yes, there are still areas where both the parties has to evolve, but awareness, knowing the product, designing a good product for your newer product for specific population of cancer patients is also one important aspect we how to take it forward. And I think we have covered most of the questions. And thank you again, CRSF, OHAPO, Vivek, for the opportunity. And I conclude here. Thank you. Thank you all my panelists. Thank you.
Thank you, Dr. Bharat.
Thank you.
Thank you so much, Dr. Bharat.